This is the 14th episode of our OvarLive, and I am Runsi Sen, and I'm the founder and president of Overcome. Today we are joined by Dr. Aparna Kamat. She is on our Overcome board, and she's also the division director of gynecology oncology at the Houston Methodist. We are here with Dr. Kamat to talk about genetics and ovarian cancer. November is Family Health History Month, and we are ready to take a DNA dive with Dr. Kamat, and we invite you to grab a chair and join us for this conversation for the next 20 minutes or so as we talk to Dr. Kamat and learn more about everything ovarian cancer and genetics. So as you join in, announce your name, give us a wave, a like or a hello as you come in, and we also strongly encourage comments and feedback if you have any. So if you have any questions for Dr. Kamat as we go along with the discussion, please type in those comments and in the comment section as you watch. And this is your opportunity to ask the expert real time. And remember, all questions are great. So with that, thank you, Dr. Kamat. It's a big honor to have you with us today. And we have a lot to discuss, so I'm just going to delve in. So my first question is, November is Family Health History Month. And so what message would you have for our audience with a family member that diagnosed with ovarian cancer?
Okay. So first of all, thanks a lot for having me, and it's been great to be a part of Overcome and doing all the things that you do to help bring awareness for women who have ovarian cancer and also for just the general public. So, one of the things that anyone who has a family member with ovarian cancer or who has themselves been diagnosed with ovarian cancer, that one of the biggest challenges we have with this disease is that it's not found early. Most patients are not diagnosed until the cancer has spread. And so one of the biggest impacts we can make is to find out if we can identify women who are at risk. So then we can then screen them to either try to find out if they are at risk for ovarian cancer or actually give them opportunities for risk reduction procedures so that they can actually never develop ovarian cancer. So how do we do that? If you look at the general population, ovarian cancer is actually not very common. So if you live to be a 70, the lifetime risk is only about anywhere from 1.4 to 1.6%.
That's for the general population.
That's for general population. Now what happens if you have a family member? So if you have a first degree family member, that risk actually goes up a little bit to 5%. If it's a second degree family member, that risk is a little lower, but still higher than the general population at 3.5%. But if you have more than 2 family members with ovarian cancer, the risk is 7%. Now, if you think about the increment, it is a bigger risk, but it's not that big.
Doesn't sound that significant.
Exactly. But what really puts you at a significant risk is if that family history identifies you to have a mutation in one of the genes that can cause ovarian cancer, such as BRCA1 or 2, then that risk can be as high as 40 to 50%. So our goal is to, number one, identify that group of patients based on family history. Number two is to identify those patients in the intermediate group who have a family history but don't have a mutation, so we can give them strategies for keeping a close eye and monitoring. But to me, the biggest message of this study, of this talk, is that 40% of women, who actually have ovarian cancer have no family history and can have a BRCA mutation. So it's the most important thing. If you have a family member, the first thing to do is to find out if that member got genetic testing or not. If for some reason that member has passed away from their cancer, then just based on that family history, you do meet criteria for genetic testing. And it's extremely important to get that, because once you have that knowledge, there's so much you can do to prevent the cancer from happening. Or if you decide not to have a definitive surgery, you can even have so many other non-invasive approaches to decrease your risk.
And thank you for that. I have a question on this particular thing that you just talked about, because we have had a few survivors talk to us about panel testing versus just the BRCA1 and 2 testing. For example, we were just talking to a patient the other day, and she was saying that, I did my genetic testing, the BRCA1 and 2 testing, it's been a few years, right? And when the panel wasn't available. So the question is, for those patients, then patients or family members, would you recommend them to do another repeat test for them to go back and do the panel testing?
So that's a really good question. So yes, it's very, very important. So in the past, a lot of women actually with ovarian cancer never got genetic testing, just because it was not so well known. Those who did get genetic testing, a lot of them got the old tests, which were just looking at BRCA1 or 2. We now know that there are a lot of other genes which are single genes which can actually increase their risk of ovarian cancer, such as BRIP1. I mean, there are many other genes which are now included in the big panel. So if those patients who were negative for BRCA1 or 2, they can now get reflex panel testing, and they would be eligible. So actually, I have a patient of mine who was diagnosed with stage 3C ovarian cancer. She was negative for BRCA1 or 2, and then her daughter got testing because of her mother, and she got the panel test, and she was found to be BRIP1 positive. So then we went back and tested her mom, and her mom is BRIP1 positive.
Right.
So I think it does give us so much more information. So yes, I strongly agree that if you are negative and now you have access to the panel testing, you should
just repeat the test once more.
Yeah.
Okay, thank you. And so my next question, based on your extensive work, tell us a little bit about the genetic, molecular, as well as the physiological factors that drives the development of cancer, and particularly ovarian cancer. And also tell us about the risks of developing a secondary cancer from an inherent genetic mutation.
That's a mouthful. I'll take the first part. So, I think cancer is basically, most cancers tend to be sporadic, which means that we don't quite know what causes them, but it's an interaction between many things. Your own genes, your environment, environmental exposures, diet. I mean, there are many things that come together to put you at risk for a particular cancer. Now, if you start talking about ovarian cancer itself, one of the big theories of why ovarian cancer develops is we think that every time women undergo ovulation, there's disruption of the capsule of the ovary, and that causes some disruption in the cells, and when they don't repair right, and that can put the patient at risk for developing cancer. So anything that puts you at a risk for incessant ovulation. So in the sense that if you start your periods very early, but then don't, so early menarche, late menopause, patients who have never been pregnant, right? So they've never had that break when they were pregnant. Women who are infertile or who have infertility. By itself, infertility can put you at an increased risk, just such as polycystic ovarian disease. Now, there were a lot of studies that looked at infertility drugs, and they thought that using infertility or drugs to induce ovulation would increase your risk. But now we know, with multiple meta-analysis that have been done, that actually the drugs itself do not increase your risk, but having infertility does.
Okay.
Then there are certain other diseases that you may have. For example, endometriosis. Endometriosis itself has been linked to an increased risk of ovarian cancer. There are certain types of cancers that are linked with endometriosis, such as clear cell and endometrioid. In fact, in Japan, where endometriosis is so common, clear cell cancer is the most common ovarian cancer that you see. So these are some of the things that can increase your risk. So the biggest risk factor, though, is once again going back to genes, is your genetic risk. So mutations in tumor suppressive genes such as BRCA1 and 2 are the biggest risk factor for developing ovarian cancer. So I think that's, not looking at all the other factors also helps, but I think if we can identify those patients who carry genetic susceptibility, that's the biggest impact.
And so if you have that genetic mutation and you're already being diagnosed with one particular type of cancer, so basically my question is, a patient who has been diagnosed with ovarian cancer, oftentimes we see that there is a possibility for that particular patient to also get diagnosed with breast cancer. So tell us a little bit about that connection and what are some of the things that
Sure.
we should be knowing?
So, if you think about what tumor suppressor genes are, these are genes that actually protect you from developing cancer. So, if you have a gene, a tumor suppressor gene that is not functioning correctly because of a mutation, it kind of puts you at a high risk of developing just not that cancer, but also a second cancer. So, actually, they have studied this quite a bit, and so women who were diagnosed with breast cancer. Within 5 years, their risk of developing a second breast cancer is almost 30% in BRCA patients as compared to 3% in the general population. If those women live to be 70 years of age, that risk is 64% for a second breast cancer compared to 11%. And that's why it's very important to use this information. So if you have been diagnosed with breast cancer and you meet the criteria for genetic testing, it's important to get it done, because then when you have your treatment, then that patient can opt for a bilateral mastectomy and prevent that second cancer. More importantly, like if you look at for ovarian cancer patients, so your risk of developing an ovarian cancer 10 years after breast cancer is almost 13% as compared to less than 1% the general population. So yes, it does put you at a higher risk, and so it's important to be vigilant. It's important to kind of follow up with your physician, and also important to be aware of it.
Of course. So my next question is, since we're talking about the high-risk women, right?
Sure.
So what would be your guidance for high-risk women with a family history of breast and or ovarian cancer in terms of, we talked a little bit about surveillance and other things, but just with someone like me who has a family history of ovarian cancer, I did do my genetic testing and it was negative. It took me 9 years to do it, but I did it. But for non-carriers like me, and then the BRCA, the 1 and 2 carriers like others, what would be your guidance just in terms of what we should be doing?
Sure. So, I think that it's important to kind of, I always talk to people, when I talk to my patients, I always tell them it's really important to risk stratify. Because things that work for one group don't particularly work for the other group, or maybe should not be done because they can be harmful. So, talking about screening, women who actually have no risk factors, all the major societies, none of us would recommend routine screening. So
and this would be the general
population, right?
With
so
no family history.
With no family history, we would say those patients just get a regular, annual physical. They don't need to have CA-125s or ultrasounds unless it's indicated. Now, in women like you, so example, you sort of fall in that middle category, the intermediate risk, because you have a family history. You are not, don't have a mutation,
right?
So you're in that 5%. So your risk would be 5% because you have a first degree relative, right? So in those patients, you have to talk to them a little bit. So if they are women who are premenopausal, one thing they can do to reduce their risk is to be on birth control pills. We know that reduces your risk of developing ovarian cancer by almost 60%, right? So that's one thing. The second thing is, we now recommend that women who are in this intermediate risk, if they for whatever reason are having a hysterectomy for benign disease, then we would definitely recommend removing their tubes.
Okay.
And ovaries, depending on where, what their age is.
So would you recommend though the removal, the hysterectomy for women that are not symptomatic or do not, like in the intermediate risk category?
No, so like I said, so we would not recommend a hysterectomy or any surgery, but I'm saying for women, for example, they have fibroids, they're having bleeding, they're planning a hysterectomy anyways, then in those patients, a risk reduction surgery, if you are in that intermediate risk, should be definitely discussed with the patient.
Okay.
And then finally, the other thing to do is talk about whether or not this group of patients should have screening. So, or surveillance. So, a lot of the big studies that have been done have shown not really that much of a benefit of surveillance, which means they're doing pelvic ultrasounds, CA-125s, and it also has shown that in these patients you can have some false positives, which increase your risk of having surgery. So, but it's an individualized, kind of approach. I usually talk to my patients, tell them about their risk, tell them what the options are, and then also tell them that if they do decide that they want to have surveillance, that it does come with a slightly increased risk of needing to have a procedure, which they may or may not need.
Of course. And then for the carriers.
So for the carriers, that's the group that we really want to focus on. So women who are young, they haven't finished childbearing. So usually in those patients, we would recommend birth control pills unless they are, they have they're trying to get pregnant or something like that. But the surveillance we usually would do is we twice a year we see them get pelvic ultrasounds, a pelvic exam, and a CA-125. But the most important thing is actually a history, just kind of see if they have some symptoms which might trigger the fact that there may be something going on which they may not recognize. So that's for the ovarian cancer. And then for breast cancer, these women usually should start breast exams by age 18, and by 25 years of age onwards, usually most people would recommend an MRI and a diagnostic mammogram every 6 months.
So for these symptomatic, not symptomatic, but the carrier patients, at what age would you recommend for them to have the genetic testing?
So most of us would recommend that they have genetic testing at age 25. So, before that, we just have looking at all the incidents, the cumulative incidents of new cases. They're so low that, there's not much that you're going to do with it. So most patients at age 25, or in the small group of patients where if you have a family member who was diagnosed, if they were diagnosed at a very, very early age, usually would say about 10 years before that first index case was diagnosed, you should start
So if the patient was diagnosed at 50, then 40 years?
No. So if 25, you start screening
so
everyone. So if you, for example, if it's a very, very, a very unusual case where you have someone who was diagnosed at say 25 or 26, then in that family, you might want to consider, starting earlier.
Okay. So and then this is a very important and very exciting time for all the treatment options that are coming in for the patients that are carriers. So how does genetic testing help women that have already been diagnosed with ovarian cancer in terms of treatment options? And what would you say for those patients who have already been diagnosed? What are the options available to them in terms of how does it map their treatment plan once you know their genetic testing?
Actually, it's like you said, this is a really, really exciting time with the new PARP inhibitors that have now been that are in the market. There are 3 different ones, and there's so many new indications for the use, not just as maintenance treatment, but also now potentially as maintenance after the initial treatment.
Right.
And the results from all these studies have shown a marked improvement in progression-free survival for all women who are positive for BRCA1 or 2. So it does open up a lot of opportunities for these patients. So I think for women who are carriers and have had ovarian cancer, the reason to know, it opens up, access to a PARP, right? It also, some of these inhibitors are also available to patients who don't have BRCA mutations. But what we know is that the group that is positive tends to do significantly better. Okay, that's one. The second thing is that it's so important for people to know their carrier status because it tells them a lot about their own cancer. So patients who are BRCA1 or 2, they may, a lot of them get upset that, oh my God, I have a mutation. But one of the things that they don't realize is that they tend to do so much better than women who actually don't have a mutation. So, just because their cancer tends to be very chemosensitive, they overall have a really good prognosis. And finally, like we touched upon before, just because you have ovarian cancer, it does, and if you know your carrier status, it will put you at a higher awareness of secondary cancers.
Right.
And so you can do something to prevent that.
That's excellent, thank you. And we have seen a few studies on this, and it's been in the press as well, that in minorities and especially in underserved communities, the rate of genetic testing is still very low. and the whole of, because we also talk to patients nationwide that through our Overcare program. So we do get this sense that the whole concept of genetic testing is somewhat limited for the minorities and as well as the underserved communities. So what would you say, in your opinion, and I know there is no right or wrong answer to this, but just in general, what are some of the things that could be done to address this particular issue?
I think in general, not just in underserved or minorities, in general, the rate of genetic testing is only 10 to 30%. It's dismally, it's very low. And referral to a genetic counselor is even lower. So I think there are many hurdles to cross. I think the biggest hurdle is to actually, have the medical professionals, healthcare providers actually buy into genetic testing. To know that it's not just a preventive, it can also help guide treatment, but more importantly, help prevent second cancers. That's one. The second thing is to transmit this information to the patient in a way that doesn't scare them, that makes them actually feel empowered, that this is actually helping them take care of their own health, and not just of their own health, but also of their families. So that's another thing. And the third thing, to me, which I think is extremely important, is to try to get away with the myth that a lot of these things are expensive, they're not accessible, that insurance will not pay for them. Actually, right now, in patients who are qualified, 90% of all genetic testing is covered by insurance. In patients, they may have a copay, but all of these, a lot of these, companies that do genetic testing have a lot of programs that will help, patients to get access to genetic testing. So I think it's just really important to have those resources available to patients. But I think at the end of the day, the only way genetic testing will improve is awareness. I mean, programs like this to kind of help people know that these are available, but also to use it wisely. I mean, I don't recommend that everyone after listening to this goes and asks for well, I want to get a genetic test. That's not how it should be. But at least be aware that this is something that is available. Talk to your health, your physician, and see what they say. But I think opening up a dialogue is probably the most important thing.
Okay, and just building upon that, there are several tests that are available in the market these days, right? That have made genetic testing a lot more easy and accessible. You can just do it from your living room, kind of thing.
Sure.
So tell us a little bit about the benefits and challenges for these kinds of tests, because like you said, there needs to be awareness on making genetic testing available and accessible, but at the same time we need to know whether that's the right thing for all of us to do, and what should we do with that information, and if we basically just overall, what would be your guidance for all these home tests that are available in the market?
So I actually think it's a really exciting way to approach genetic testing. I mean, like I said, some of the big hurdles were, going to see a genetic counselor, an extra appointment. It's a lot of, people who are, going through cancer treatment, or they have other things to do. It's one more thing to do. So if we can make this easy and remove some of the, it is helpful. Now, that being said, though, so I think it was March of this year that the 23andMe, panel was included BRCA1 and 2 testing. And the thing with that is it kind of covers only the 3 founder mutations for BRCA. It doesn't include the entire panel. Now, it is a good start, but if that is negative, the problem is that if that's negative, a lot of people are going to feel reassured that they don't have a risk. They don't know that they probably need to have the big panel, especially if they have a family history. So I think that is one of the pitfalls of doing the testing at home. If you do the testing at home and then can have follow-up with a healthcare provider or a counselor to make sure you understand what the test means,
or what you might have missed in the whole process.
What you have missed, I think is the key. But I do think that as we go forward with some of the studies that are being done right now, you will see more and more that this is something that can be done in the comfort of his own home, and then followed up with a visit with a counselor to understand those results and then make any appropriate treatment plans.
And I think you touched on a very important point, that even if you're doing this at the comfort of your home, it's very important for all of us that are doing the test at home to go back and check back with your physician or the counselor. In my case, I actually went to the hospital, but just talking about those hurdles that you just mentioned, time comes in the way and you're busy with your life, and it took me several years before I took the step to go do the genetic testing. But this definitely makes it easier, but at the same time there needs to be a step B for all of us to just take that step and talk to your doctor or your counselor to understand the results of the test that you took at your home. Thank you so much for that information. And my last question to you, as our survivors and the community that follows us, they're watching and they'll be watching later, what is your message to the survivor community as well as the family members as they go through the treatment for ovarian cancer, and also for the daughters or the other immediate family members that have family history?
It's hard to give one message, but I do feel that even if patients who have already been diagnosed with ovarian cancer, I think it's so important to find out what your risk is. I think because we know the genetic risk is the biggest risk factor. So if you can stratify yourself by knowing what your genetic risk is, by knowing what your genetic testing or mutation status is, then that helps you empower yourself to, number one, either seek treatments that can target your cancer if you're positive. If you're positive, then identify ways you can prevent second cancers, and then obviously tell your loved ones that they need to be tested so this never happens to them. But I think my biggest message to survivors, to anyone who's involved with anyone who's had ovarian cancer, is really to just increase awareness. I think you'll be surprised at how much of a difference it makes once you are armed with some knowledge and not just going off fear, because I think that can go a long way.
Well, thank you very much for your time. Do we have any questions? We do not have any questions, so thank you for watching, and we'll be back next time with the next edition of OvarLive. So thank you very much for joining us.